Good afternoon. Assalamu alaikum. On behalf of Institute for Population Health at Weill Cornell Medicine in Qatar, I welcome you once again to the Population Health and Wellbeing series. As a reminder, the objectives of the series are threefold. One, discuss contemporary and critical topics relevant to healthcare, medicine, and population health. Two, examine evidence-based practices germane to public health and patient care. And three, describe opportunities and challenges in the evolving face of healthcare and population health. Some housekeeping notes. Your cameras and microphones are turned off. Use the Q&A feature to type questions and comments that you might have. And finally, that questions will be addressed at the end of the session. And that session, that small session, mini session, will be overseen by Dr. Suhaila Chima, who's the Assistant Dean with us at the Institute for Population Health. This activity is accredited by the Accreditation Council for Continuing Medical Education in the US, and also by the Department of Healthcare Professions of the Ministry of Public Health in the state of Qatar. Insofar as evaluation and certificates are concerned, please note the following. The post-activity evaluation will be available in your Cloud CME account by December 2020. Well, it'll be a few days afterwards. You will receive an email notification once the evaluation is available in your Cloud CME account. Your certificates will be available for download once you complete the post-activity evaluation of the Cloud CME portal. So that's our seminar for today. And it is now my pleasure and a privilege to introduce my friend and a great colleague, Dr. David Katz. David is a preventive medicine specialist and a globally recognized authority on lifestyle medicine. He's the founder and former director of Yale University's Yale Griffin Prevention Research Center, past president of the American College of Lifestyle Medicine, and president and founder of the not-profit True Health Initiative. Dr. David Katz earned his Doctor of Medicine degree from the Albert Einstein College of Medicine and his Master's of Public Health from the Yale University School of Public Health. A recipient of numerous awards for teaching, writing, and contributions to public health, Dr. Katz was a 2019 nominee for James Beard Foundation Award in Health Journalism and has received 3 honorary doctorates. He has published over 200 peer-reviewed papers, written many hundreds of online and newspaper columns, and has authored or co-authored 18 books to date. Recognized by his colleagues as the poet laureate of health promotion, David has given keynote addresses in all 50 United States and in many countries on 6 continents. So with that brief introduction, please join me in welcoming our colleague, our friend, Dr. Katz, to this virtual podium. David, please take it over from here.
Robbie, thank you so much. Good afternoon, everyone. It's wonderful to be with you. Robbie, can you confirm that you're seeing my slides now?
Yes, absolutely.
Very good. Very good. Excellent to be with all of you. We had a timing snafu last week. My apologies for that. I'm glad we were able to sort it out. Let me take the opportunity as well to wish you all happy holidays. It's morning here in snowy Connecticut in the northeastern United States. I imagine it may be looking a bit less like the prevailing pop culture version of Christmas where you are, but you know, it's a Currier and Ives scene outside my window here, which is lovely. It's great to be with you. And Robbie, I appreciate so much the invitation. I look forward to post-pandemic days when we can get together in person. These days, it's all interacting this way as disembodied spirits. It's the next best thing to being there, but being there would be better. I look forward to that. So without further ado, let's talk about the case. Pardon me. For looking both ways before crossing a busy pandemic. My disclosure statement is there is none. I opined early about the pandemic as an epidemiologist, preventive medicine specialist, kind of get sucked into the vortex of it all, and have been trying to keep up ever since, pretty much drinking from a fire hose. But by and large, no compensation at all for any of this. It really isn't my day job. I don't work for the CDC, and there will be no off-label drugs or products to discuss here. If I bring a unique aptitude, and Ravi's introduction was characteristically very kind and generous, if I bring a unique aptitude or attribute to the conversation today, it's a tendency to see the big picture. You may all be familiar with the famous parable of the blind men and the elephant. It was 6 men of Indostan to learning much inclined, who went to see the elephant, though all of them were blind, that each by observation might satisfy his mind, and on it goes. And of course, the point of the parable is each man takes hold of a different part of the elephant and reaches a completely different conclusion about the whole. And there is that tendency, I think, that reverberates throughout all of epidemiology. I have this native inclination and tendency to see the big picture. And that means if there's an elephant in the room, I'm your guy. I'm likely to spot it. And in the case of a pandemic, there certainly was an all-out elephant in everybody's room. And in order to take it in all of its parts, from tail to trunk, you really did need to step back and look at the big picture. And I think I may have done that, in a somewhat unique way and early on. So from the earliest, and you see the date here, this was last February. So this was just about the time we were beginning to get data out of Wuhan, China, and then quickly thereafter out of Seoul, South Korea, but from nowhere else yet. I was sensing in the zeitgeist, in my access to large populations through social media and my writing, a burgeoning anxiety about all of this. And although it was already clear that the possibility of a severe pandemic was looming, even so, even if you go all the way back to the horrendous flu pandemic of 1918, which of course was compounded by World War I, the likelihood of any given individual being killed by the flu, even then, 100 years ago, was relatively low relative to the world's population, right? We were already a population of a couple billion at the time. The death toll ultimately, was well over 100 million. That's a very, very big number, but still a tiny fraction of the world's population. It seemed very unlikely that the COVID-19 experience would be anything to rival 1918. And that, by the way, thankfully is true this far into it. So the likelihood of any one person being a victim of the pandemic, particularly relatively young, relatively healthy people, was extremely remote. So I started to write about that and say, look, we do risk distortion. We do it all the time. If it's new, if it's shiny, if it's in the headlines, if it's in every news cycle, if it grabs our attention, it looms much larger than its actual relative contributions to epidemiology. Let's get a grip early, but before this starts to roll over us, let's get some perspective. So that was my early contribution. But it was informed by something else. I was aware that we were just beginning to emerge in the United States from an opioid epidemic. So we already had an epidemic, and it had been declared a public health emergency here. It's been a problem in other parts of the world as well. In the United States, it was severe enough we actually had seen a decline in overall life expectancy. And that was driven by what we have traditionally referred to as the social determinants of health. People's economic status, their social status, their environments, their interactions with family, their community. When those things are disrupted, people suffer. That had been happening. That was still happening. We were only just beginning to emerge from that crisis. And I thought, wow, if we get the policy responses to the pandemic wrong, we shut everything down, send everybody home, and that means a whole bunch of people who need a paycheck every week stop getting one, we are going to reap a whirlwind. We're going to disrupt the social determinants of health. We're going to hurt a lot of people. And I was really concerned about that. And then the information started to flow. So we began to hear in our major news outlets that we were going to have something to rival the Great Depression of the 1930s. And of course, the economic pain of that was very overwhelming for the population, resulting in depression and suicides and all sorts of significant harm at the level of the population. And once people are anxious, desperate, isolated, maybe hungry, a whole host of bad things start to happen. Child abuse, domestic violence. And we started to see reports, this was last April, that domestic violence was rising around the world. In the United States, we had a spike in gun sales. I was a little bit mystified by this right from the start, wondering, okay, who exactly is going to get shot here? Because it's going to be very hard to point this at SARS-CoV-2. What the heck are all the guns for? This was a very disturbing trend. And in fact, these months later, we have seen a spike in violence and homicide in all major cities throughout the United States. By the way, my friends, forgive the inevitable ethnocentrism, right? I'd love to be speaking about the epidemiology of Qatar. I don't know it nearly as well as many of you do. But, we're talking about a pandemic, so any one window to what's happening at the level of a whole population is probably somewhat indicative of how we're all suffering and how we're all struggling. But forgive me, inevitably, it's my window that I know best that I'm looking through, and I do apologize for that. There's been concern about elevation in suicides all around the world, and some data now to support this. This is a hard statistic to track. And, actually, one of the interesting things from the perspective of epidemiology is we're not accustomed to real-time reporting of major global trends. Usually what happens is we have various ascertainment mechanisms. In the case of nutrition, we have a survey called NHANES, National Health Nutrition Examination Survey. In the case of behaviors, we have the BRFSS, Behavioral Risk Factor Surveillance System. But ordinarily, the way this happens is we collect data from a representative random sample during some portion of the year. Maybe we do it for several years in a row, but you get the data for an entire year. That year closes out, the calendar moves on, and then some number of months later, the data analysis is completed, the data report becomes public. In other words, you don't know what happened in 2020 until well into 2021 or maybe even 2022. And sometimes you're looking back from a vista 3 years at the close of the data collection period, certainly in the peer-reviewed literature. The pandemic, Ravi and I were talking about time before we opened this up to all of you, trying to remember the last time we saw one another, and I visited Qatar. But the pandemic, has completely distorted time. I think during the pandemic, a week is a year, a month is a decade, and the pandemic itself is many lifetimes. So, it's really changed the way we process epidemiologic information. But it's really hard for all of the other data repositories to catch up. So, we don't have a system in place to track, analyze, and report global statistics in suicides in real time, so we know every few months how it's changing. That's the kind of information people want during the pandemic. Okay, here's what COVID did in this quarter. What happened in terms of suicides or other chronic diseases? So there's a scramble here to try and make these comparisons. But we do have indications that suicides are rising. We certainly have clear evidence now that we are back into the opioid emergency we were just exiting, with rising rates of overdose deaths in the United States. And as best I can tell, these are CDC data, they're US specific. As best I can tell, this is a global trend. Pardon me, I get early morning throat here. Forgive me for that. So you add all this up, and you get an article like this in Health Affairs entitled "Not Social Determinants of Health, but Social Determinants of Death." And we were in fact witnessing not so much SARS-CoV-2, but our societal responses to it, transforming social determinants of health into the social determinants of death. Well, as an epidemiologist and a humanist, I found this deeply disturbing and thought, okay, there is more than one way for this pandemic to hurt people. We need to be cognizant of and sensitive to all of them. And we need to start thinking early about how are we going to manage and minimize all of them. So that was my agenda as I became a figure in the commentary about the pandemic. Raji, this would be then the first polling question. How much do you think long-term unemployment at midlife reduces life expectancy on average? And the answers are flowing in, so we'll just give this a couple minutes. Well, less. Now, I know that there are well over 500 of you, so you need to see these numbers spike up. Otherwise, some of you are coasting. No coasting. Everybody say something. I guess some of you were just reflecting. Hard to argue with people for taking the time to reflect. That's a good thing. All right, Raju, why don't we stop the poll, show the results. So it looks like 3 years is the winner, but a pretty good distribution. And the second guess was 1.5 years, lesser for the extremes, 1 year and 5. Okay, so 1.5 to 3 years seems to be, everybody seeing these results? I guess not. Now you are, and I'll stop sharing those. Closed out that question. Okay, so in data that I first encountered in a webinar I did with Nick Bloom, who's an economy professor at Stanford University in California, he cited some of this primary literature indicating that indeed it's about a year and a half, so year to year and a half, but year and a half is the prevailing figure. A year and a half of life expectancy lost if someone loses a job long-term at or around age 40. So again, apologies for the ethnocentrism. Here in the United States, we have seen a loss of about 50 million jobs related to the pandemic. And it's been estimated throughout that half or more of those would be long-term, maybe not permanent job loss, but certainly long-term job loss. I'm going to make this easy on myself and say 20 million jobs lost for an extended period of time at or around midlife. Let's just do a little bit of quick math. We've had about 300,000 deaths in the United States attributed to COVID. And the estimate that prevails is on average 10 years of life are lost when someone dies of the virus. I actually don't think that's true. And I'll tell you some of the reasons why as I proceed, but I think it's probably less. But we'll use 10 years of life lost per person who dies of SARS-CoV-2, 300,000 deaths to SARS-CoV-2 here in the United States. 300,000 times 10 equals 3 million years of human life lost. That's a tragedy. But let's just pause to feel the solidarity of our condolences for every family touched by that. You know, at this point, with 300,000 deaths, most of us have been touched by this. It's true all around the world. We're now not at very many removes. It's either it's a friend or family member, or it's a friend or family member of a friend or family member, but we're all pretty close now to the direct impact of the pandemic. So my condolences to all of you who have been affected by this. Certainly I have. So 3 million years of life lost is a tragedy, but 30 million years of life lost is no lesser tragedy. It doesn't matter that 10 times as many years of human life have been lost for reasons other than infection with SARS-CoV-2. And that's what this math is telling us about social determinants. If 20 million people have lost their job around midlife for an extended period of time, and there's a year and a half of life lost every time that happens, 1.5 times 20 million is 30 million. And even this far into the toll of SARS-CoV-2, that's 10 times bigger than the toll of the virus itself. I don't think any humanist can ignore that. And actually I did a CNN interview early on and was talking about this and was barraged with hate mail, you know, talking about the comparison of lives to dollars. No, absolutely not. I'm not an economist. Nick Bloom is an economist. I'm not. I'm a public health physician. I care about human lives. It's really the only currency that's ever mattered to me. This is lives versus lives, not lives versus dollars. There's just more than one way for a pandemic to hurt people. And those of us who care about and for people have to care about all of them. And we have to try to do something to mitigate them all. So I told you I don't believe the 10 years of life lost per person. And part of the reason I have strong opinions about the pandemic is I went to see it up close and personal. So I'm an internist. I did clinical care for 30 years. But several years ago, I stopped seeing patients to focus full time on my efforts in public health. But when the New York City hospitals were overwhelmed last spring, I'm still a licensed physician. It's a little bit like riding a bike. I still kind of remember what you're supposed to do. So I volunteered through the system and was deployed in an emergency department in a hospital in the Bronx, which was pretty much the epicenter of the pandemic at the time in the Montefiore Health System. So this is an image of me in front of my colleagues in the emergency room during my shifts there. It was a very small contribution to the fight against the pandemic. I did several shifts. It was about a week's worth of work. My aim was not to be here I am to save the day. It's just I thought everybody who can make a contribution should, and I can, so I will. But it also was extremely valuable to me because it fortified my understanding of all this. I've seen people die of COVID. I've seen people on the brink of dying of COVID turn the corner and come back. I've seen them go on ventilators, not go on ventilators. I've seen the lab panels that come in and all of that. And I also saw the people who were coming in. So in a number of shifts in this emergency department, I saw how many of the ambulances bringing in seriously ill people with COVID were coming from nursing homes, and how many of these people were elderly and quite sick before they ever got COVID, which is why I doubt the 10-year figure. A lot of the mortality here is compressed and concentrated in people who are elderly and who were quite sick to begin with. We also saw a number of young people come in, some of whom had COVID and were oblivious to it. They were in because they had a laceration that needed to be sewn up. And oh, by the way, that their test revealed they had COVID. They didn't know, and it was inconsequential. So you really got to see the spectrum of the disease. But it was important to me not to be an armchair epidemiologist, as one of my former colleagues at Yale accused me of when I started to opine. I went to the front lines to really understand what was going on. And informed by these various perspectives, my opinion wound up in the New York Times, where I wrote this piece, "Is our fight against coronavirus worse than the disease?" And what I was asking is, will we hurt more people with indiscriminate lockdown that is inattentive and insensitive to the risk variations associated with this infection than are actually hurt by the infection? And it doesn't even matter if we hurt more people with lockdown. It only matters if we hurt additional people with lockdown. Even maybe the virus is worse than lockdown, but if lockdown hurts more people, maybe there's a better way, a more surgical strike. Now you think about whether it's surgery, where you obviously want to minimize damage and harm to surrounding tissue, or you think about a military analogy where you want to minimize collateral damage or friendly fire. Either way, we were engaging in all-out open warfare with SARS-CoV-2, and I was watching people hurt to left and right by the armaments we were using, shutting everything down, keeping everybody home, closing schools, and that goes on to this day. That concerned me. And then my perspective on the pandemic was picked up by 3-time Pulitzer Prize winner Tom Friedman, expert in the sociopolitics of the Middle East, by the way, and a long-term columnist for the New York Times. So Tom and I started to confer. We've since become close friends. He channeled my opinion in a subsequent column he wrote, and we've been doing that pretty much ever since. And so here I am. Whether or not I deserve to have the prominence I do related to the pandemic, I don't presume to say. My mother certainly thinks so. I don't know that there are too many other people in that club. Thankfully, Tom Friedman is one of them. But I did have a novel perspective, and it did get pretty high profile exposure. And what I tried to do all along was keep the big picture in mind, find the relevant experts who were speaking science and sense, and to channel them. Among those experts, and I found many, because after the exposure in the New York Times, a who's who in the world of epidemiology, public health economics, all found me. So I had the privilege of conferring with the best and brightest from all around the world. This couple contributed a lot to my understanding. Maria Cecchina is a professor in mathematics at the University of Pittsburgh here in the US. Wes Pegden is University of Mathematics at Carnegie Mellon University. They're a couple. Very early on, they published a piece on Medium arguing that we weren't being honest about pandemic modeling. This is back at the time when we were hearing flatten the curve, just flatten the curve. Everybody needs to flatten the curve. And I thought, yeah, okay, we need to flatten the curve, but what happens after? Flattening the curve, it seems to me, is just, you keep, it's almost like, it's your finger in a hole in the dike, right? You're not letting the water flow out, but you can't ever walk away, because the minute you do, you release the flood. And so the same thing here. I mean, how do we stop flattening the curve if our only plan is flatten the curve? So they published this piece that essentially said exactly that. They actually took an infographic published in the New York Times, found the mathematical model used for it. So they didn't invent or create or design anything here. They took the model, and actually this was in an article by Nick Kristof, another columnist at the New York Times I admire very much, but he published this graph provided to him by an epidemiologist. These two, Chikina and Pegden, went into this tool, turned it back on, and said, okay, yep, you look at the top graph, this is what was shown in the New York Times, we'll have 130 million total infections if we don't flatten the curve, we'll only have 14 million infections if we do. But look at that curve to the right at the top, it stops, on or about October 1st. They simply ask the question, what if the calendar continues? What happens if November comes and you keep going and you don't just flatten the curve forever? You don't keep everybody locked in their basements forever. Well, what happens is you actually get more total infections and more total harm, because you've kept people and virus apart. The virus is still circulating. Everybody's vulnerable. Nobody has immunity. In other words, if your only public health policy is flatten the curve, you save no one. You just change the dates. And this to me was obviously important and ominous, because all I was hearing was a society-wide chant to flatten the curve, that we are missing the big picture. There is a rampaging elephant in the room, and I feel like I'm one of the few people seeing that. We have got to take in the bigger picture. So from that point in the pandemic till now, I started channeling all of the information I could get from real experts again. And what I was looking for, there's a lot of highly polarized opinion in the world today, and especially about the pandemic. And here in the United States, we've had leadership, so-called, for the past 4 years that has actively encouraged that kind of polarization, terribly detrimental to our society, but really horrendously detrimental to our pandemic response. So I was looking for people who were, apolitical and willing to speak from a platform of science and sense, and recognize the big picture. And what we started talking about was total harm minimization. The virus can hurt people, lockdown can hurt people, hurting people is bad, helping people is good. Any which way they're harmed is bad, any which way we prevent it is good. Let's talk about that. What are the strategies? What are the tactics? What are the public health policies that are aimed at total harm minimization? And this, by the way, is readily available to all of you. We created a vast archive on the pages of my nonprofit, the True Health Initiative. So just go to truehealthinitiative.org. You can find the COVID page, and you'll find peer-reviewed papers and commentaries and blogs and mathematical models and the entire argument for total harm minimization. Oops. And the harm minimization we were talking about needed to be informed by risk stratification. And one of the things that I argued, I had the opportunity at one point in the pandemic to testify to the Committee on Homeland Security of the US Senate. And when the senators there were questioning me and the others, one of the issues they raised was that, well, in order for us to stop flying through a dense fog and know what's what, we need to do millions and millions of tests, and we don't have millions of test kits. We still don't have enough test kits, but we certainly didn't back then. And I said, no, I disagree. Everything we know, my day job is focusing on chronic disease prevention by means of lifestyle, in particular diet. So, ordinarily I'm tracking nutrition data. Well, everything we know about dietary intake data in the US and around the world comes from representative random sampling. We don't test what everybody's eating all the time. We use the NHANES system. We do representative random sampling in some number of thousands, I think it's 14,000 routinely in the US, and then extrapolate that weighted sample to 330 million people. We could do exactly the same thing for COVID. We don't need to test millions, we need to test thousands and extrapolate. We just need the thousands to be carefully sampled so they represent the rest, all ages, both sexes, different parts of the country, all the usual parameters. And what we want to do is build a data pyramid where we know everybody, we know the demographics, we know everybody who's been exposed. Of the exposed, we know who's been infected. Of the infected, we know who's developed symptoms. Of those who had symptoms, we know those who sought medical care. Of those who sought medical care, we know who wound up in the hospital. And of those who wound up in the ICU, and of those who wound up on a ventilator, and of those who wound up dying. And if we build that pyramid, we'll have a detailed understanding of not just the scope of the pandemic with extrapolation to the whole population, but the risk tiers. And we can climb that data pyramid, get up above the haze and the fog, and get a clear picture of what's going on. We never built this pyramid. Even to this day, you know, we've cobbled together a really poor approximation of it, with scientists doing what they do in an uncoordinated manner, but we never had a systematic national effort to build a data pyramid that we could climb to have this deep understanding. Inexcusable deficiency in our response to the pandemic. It never happened. But even in the absence of that, because we were able to cobble together a lot of information and look at the deaths, and by the way, 40% of the deaths here in the US have been concentrated in nursing homes. Now, it means two things. It means we should have protected nursing homes much, much better than we did. But it also means that SARS-CoV-2 is not a one-size-fits-all threat. Never was, still isn't. It is highly dangerous to elderly sick people, and then decreasingly dangerous to people who are less elderly and less sick. So I put together, this is mine, this color-coded risk matrix, where I looked at age across the top and disease burden along the sides. And obviously this is crude, right? This could be broken out into many more cells. The thresholds between cells could be defined operationally and in more detail, but this is just to convey the gist that people in cell A need highly meticulous protection against exposure to this virus. These are the people that do need to hunker in a bunker until they can get vaccinated. Cells D and B, a little bit less so. Cells G, E, and C, the intermediate yellow cells, intermediate risk. The green cells, low risk. Cell I, extremely low risk. So what if we think in terms of policies that correspond to these risk tiers? Youngest, healthiest people, well, you know, maybe we needed a lockdown for 2 or 3 weeks while we got our bearings, figured this out, and then said, okay, people in cells I, certainly, and probably F and H here, can go back to their business, out into the world, and then we will monitor them very carefully to see whether or not the virus circulates among them. We expect it will. And whether or not it hurts anybody, we expect it won't. I mean, not nobody, right? I mean, you know, there's no zero risk in all of epidemiology, but, you know, the risk of them being harmed by the virus is lower than the risk of them being harmed by going to and from work every day. So they should go to and from work every day, take their usual chances out in the world. And by the way, this is a path to herd immunity. Herd immunity in our response to COVID-19 has become heresy. But, you know, you're people in medicine and public health, you know it's not heresy. Herd immunity just means enough people are immune, the transmission stops, and the non-immune are now also protected. It's communal protection. It's all of us protecting ourselves and one another. And herd immunity can be achieved either with natural infection or with vaccine or with a combination of the two. Either way, whether it's the vaccine or the virus, the goal is herd immunity. But one way to get there would be to risk stratify the population. The low risk go out first, and then people return to the world in phases, kind of like putting your toes in the water before you dive in to see, you know, is the water cold or can I go in comfortably? Same thing here. If low risk groups, they circulate the virus, recover, make antibodies, and nobody is harmed, okay, let's try the next risk phase and then the next. And then let's keep cell A carefully protected from the virus until either A, we have a vaccine, which we now do, of course, or B, everybody else has already returned to the world and is now immune, and viral transmission levels are near zero, and it's over. There was another way to get to the end of all this if grown-ups had been running the country and the world. And unfortunately, the management of this pandemic was a case study in how not to manage a pandemic. I had another major concern that I brought with me into this, and I wrote about this early on as well, and that is we are really biased in our perception of risk to human well-being. We're not remotely consistent. Because if we weren't, frankly, hypocrites who get really excited about the new and shiny while ignoring what's been here all along, we would be deeply concerned about pandemics of chronic disease. You know, there's a saying, I trust all of you know it, familiarity breeds contempt. Well, it certainly seems to be the case with the pandemics of type 2 diabetes and obesity, hypertension, dyslipidemia, coronary disease, on and on it goes. And these pandemics are driven by lifestyle factors we completely control. There are aspects of SARS-CoV-2 we really don't know how to handle, right? We're in an arms race between our immune system and defenses and our science and the adaptations of the virus. And before I'm done, I'll talk about the mutations and the new strain that's in the UK and presumably now populating the world as well. But that was inevitable. That's what viruses do. They mutate, they evolve, they adapt. So we're not completely in control of that situation and never will be, but we're completely in control over lifestyle factors like diet and exercise, and they are responsible for a vastly greater pandemic. So Raji, polling question 2, what's the annual mortality of poor diet quality here in the United States? And I'm looking on as the answers come in. I'll give this another 10 seconds or so. All right, and then, you know, I'm just saying, I see there's still a lot of you not committing. It's okay. Okay, we've given that a full minute. Raji, we can close the poll, and if you would, please show the results, and let's share those with everybody. So the winner here was 10,000. So remember, the population of the United States is 330 million. So you are suggesting that 10,000 people die of poor diet quality. But a lot of you are saying, no, it's 10 times bigger than that. It's 100,000. And then the other answers were less popular. Let me stop sharing that and give you the answer. So this time, so last time you guys did very well. You nailed it. Actually, poor diet quality is estimated to kill 500,000 people, 500,000 people in the United States every year. So remember, at this point in the pandemic, SARS-CoV-2 has killed about 300,000. Poor diet quality is estimated to kill 500,000 every year. You know, talk about the elephant in the room. This pandemic is high, and it is a pandemic, by the way. It's obviously, you know, the U.S. has done a masterful job of exporting junk and making it a food group around the world. Yay us. So this is a global problem. 500,000 deaths a year. What I'm showing on the slide is an op-ed in the New York Times from last year, August 26th of 2019, by Dariush Mozaffarian, whose name you likely know, Dean of Nutrition at the Tufts Friedman School of Nutrition, and Dan Glickman, whose name you may not know, former Secretary of Agriculture of the United States. And in this article, they cite the primary literature, which I could also show you, but why don't you just Google this article and you'll pull it right up. Global Burden of Disease Report in particular from the Lancet and JAMA, indicating that 500,000 people die of poor diet quality. And by the way, you know, this doesn't mean just nutritional inadequacy. It also means an excess of junk food leading to obesity and diabetes and heart disease. So it's all of the deaths that are related to diet. And then, frankly, the number is probably bigger because we have 655,000 deaths a year in the United States from heart disease, and overwhelmingly that's related to diet. So 500,000 is probably the low end here. And my point is, you know, we're completely inattentive to this. This is year in, year out. We're causing obesity and type 2 diabetes in kids. Where is the outrage? Where is the response commensurate with the response to the pandemic? And the answer, of course, is we have none. But the two also come together in a critically important way. And colleagues and I have done several papers looking at the contributions of these chronic conditions that are fed by poor diet and adverse lifestyle to the COVID pandemic. We published this in the Journal of Emerging Infectious Disease. And we found basically that here in the US, again, once again, apologies for the window I keep looking through, 6 of 10 adults have at least one of the major risk factors for an adverse COVID outcome. 4 in 10 have 2 or more, and you see the conditions down at the bottom. But in particular, we're talking about cardiometabolic liability, so obesity, hypertension, heart disease, diabetes. 4 in 10 have 2, 6 in 10 have 1. A majority of adults in the United States and in modern countries throughout the world, and Qatar is not too different, are at elevated risk for bad COVID outcomes because of totally fixable stuff that is a result of lifestyle. This was picked up in the New York Times. Nadia Popovich talked about this overlap between chronic conditions and acute threat, and this further overlaps with socioeconomic disadvantage. We've had intense struggles related to racial justice in the United States. That's an issue. So we're talking communities of color and socioeconomic hardship and a massive burden of lifestyle-related chronic disease, and, oh, by the way, increased risk for bad outcomes from COVID acutely. Obesity is a particular risk factor in younger people, probably the single biggest explanation for really bad outcomes in young people who otherwise should do quite well is obesity. These mechanisms are under active investigation even now, but by and large, these conditions, obesity, hypertension, diabetes, coronary disease, and forgive me for going through these slides quickly, they share a common pathway of inflammation. Essentially, they impair immune system function, and so does bad diet. So bad diet feeds the vulnerability to all of these major conditions and then directly interferes with immune system function. As I trust many of you know, we have studies to show that this influence begins just about immediately. And this is true of other lifestyle factors as well, exercise. But the difference between a high quality meal and a low quality meal can be demonstrated in 2 key measures related to immune system response. One is endothelial function, changes postprandially. It's impaired by junk if we eat it. It's also impaired by being sedentary. And the other is chemotaxis, which is a direct measure of response by immune system cells. Chemotaxis is impaired by a junk food meal in the hours following the meal. It's not just over time. It's not just whether you do or don't develop obesity or diabetes. Today, your immune system response will vary based on whether you eat high quality food or junk, whether you exercise or sit on the couch. So that's obviously relevant to what's going on in the world. And so we looked at that. This paper is still a preprint, hoping to get this one published. And we saw that it was potentially possible to reduce hospitalization related to COVID by as much as 40% just by addressing these cardiometabolic liabilities that prevail in the modern world with lifestyle interventions. So I've argued that you could make the case that 2 pandemics are actually better than 1. If we just had the 1 pandemic of SARS-CoV-2, we'd all be hunkering in our bunkers waiting for a vaccine and hoping not to get it. Or we could say, wait a minute, a lot of us are vulnerable to bad outcomes because of chronic conditions we can fix. And if we fix them, then A, well, we're fixing them, and that's a good thing intrinsically, and B, we're acutely reducing our risk for bad COVID outcomes, and that's another good thing. And that issue of timing, acute versus chronic, is really important. Again, familiarity breeds contempt. But the other issue is the human nervous system is hardwired through adaptation to respond to acute threats, right? We talk about the fight or flight response. You don't activate the fight, flight, or freeze response by telling someone you're at risk for getting diabetes or heart disease in 10 years. You activate that response when something is coming at you that you can perceive as an immediate threat, right? The siren goes off behind you, you get startled. But COVID does that too. People are worried about getting COVID and dying next week. There's an acuity of concern there that chronic disease does not evoke. And consequently, there is an opportunity to address the chronic pandemic through the portal of worry about the acute pandemic, saying, hey, let's take advantage of this and fix both. So there's an opportunity for health in the time of the coronavirus. And I would argue, Ravi and colleagues, maybe this is something Qatar can lead the world in. There's never been a better time for a national health promotion campaign because we can reduce and attenuate acute risk by improving chronic health. We talk about chronic disease all the time. We don't really talk routinely about chronic health, but there's an acute case for chronic health as one of the best defenses against this pandemic and every other. And if we did this, we would be adding years to lives and life to years along 2 channels: defense against the chronic lifestyle-related diseases and defense against COVID. This is the time. I haven't seen any nation step up to own this, and that's a shame. There are new means of doing it. Now, obviously, a lot of what we're doing with patients is shifting to these virtual interactions, telemedicine. And with the burgeoning reach of telemedicine, we can reach people with new tools. Just this year, the American College of Cardiology recommended that diet is so important, 500,000 deaths a year, it really ought to be considered a vital sign. It should be measured in every clinical encounter. And essentially this notion that diet should be evaluated at every clinical encounter calls out for tools that can do that. You're not going to give a food frequency questionnaire at every clinical encounter. You're not going to do a 7-day food diary at every clinical encounter. I'm pleased to report that one of the things I do now that I've left clinical medicine, I founded a startup company called Diet ID. We've invented and deployed just such a tool. So let me invite you to check out dietid.com and see a whole new way to assess diet and make it the vital sign it deserves to be. All right, let me wrap this up so we can move on to your questions. What now? Where are we? Well, I would argue that the pandemic response has been a train wreck, certainly here in the United States, but frankly, the global response has not been a heck of a lot better. Japan's done a great job. Sweden's interesting. There are lots of models we could debate that maybe have done well. Singapore's potentially done a uniquely good job. The global response has been terrible. We've not seen global public health officials talk specifically about risk stratification, total harm minimization. I think they missed an enormous opportunity. They also haven't talked a lot about fortifying food production systems around the world so we don't have a need for wet markets like the one in Wuhan, where everybody has food security through safe channels and we're not disrupting fragile ecosystems to get food. So we should have risk stratified. We did not. If we risk stratified, we could match policy guidelines to level of risk. We could reduce risk in everybody with lifestyle as medicine. And then we've obviously got the tactics we're all familiar with: test, mask, distance, sanitize, shelter, and now vaccinate. And the news there is good. Amazingly fast development of these vaccines. I applaud that. I celebrate it. I'm sure you all do. They do look to be highly effective. It's a little early to know for sure, but so far so good, including papers now out in the New England Journal of Medicine. They look to be quite reasonably safe. That doesn't mean perfectly safe, but it looks good. And we now have 2 available, the Pfizer vaccine and the Moderna vaccine, both deployed here in the United States at this point. I imagine Qatar's not too different. So now we have to get these to people where they can do good, but it looks very promising. But this comes at a time of great urgency. My friend Steve Wolf and others just published this in JAMA, suggesting that in this moment, in all age groups above 35, COVID is the leading cause of death in the United States. Now, this is a very compressed moment. Ordinarily, heart disease has been worse than COVID, even on most of the really bad days. 1,800 people die of heart disease in the United States every day. But COVID now exceeds that. So in this moment, leading cause of death. So the vaccines are definitely welcome. But we could have mitigated risk a variety of ways up until now. And now we have the challenge I mentioned before with the emergence of this new strain, in particular in Britain, and concerns about what this portends. Just a couple of quick comments. First, no reason to think that this strain, which still produces the spike protein, will elude the vaccines. That testing is now ongoing. They're actually looking to see if they can test sample populations in the UK, show that the vaccines are effective against the mutated strain, but everybody thinks they will be. In general, viruses mutate in a way that favors their propagation, and killing people, killing your host, does not favor the propagation of a parasite. Parasites thrive and spread when they readily infect their host and don't kill their host. So severe disease is not in the interest of us or the virus, if you think about adaptation, but enhanced transmission is in the interest of the virus. That's going to be favored when mutations occur. So there's every reason to expect that we'll see new strains that spread better, but are not necessarily more virulent and could very well be less virulent. Being less virulent also is in the interest of natural selection and adaptation of the virus. Anyway, concerning, but no evidence it causes more severe disease. Certainly nothing to suggest it will be able to elude the effects of the vaccines, which do target the spike protein. These still express the spike protein. So we have to watch this closely. There'll be other mutant variants around the world before this ends, but it doesn't look to change the likely end game here, which definitely will be accelerated by vaccines. So with that, Ravi, colleagues, I thank you all for your time and attention.